What I'd like to do in the next 25-30 minutes is just to go to where we are up to with transcatheter aortic valve implantation. And it's been a very interesting ride, and I think you've seen some of it, but I'd like to give you a little bit of background first before we go into where we're up to. Most of you will be aware that this is a fairly new procedure. It's really only 10 years since Cuvier first published his series of only 12 patients. And in that period, since then, a period of 10 years, there's been an enormous growth and an enormous developmental change and iteration of the devices that we're using. And this is the projection for what will happen to transcatheter valve implantation over the next 10 years. And you can see that over the last few years, in the last 3 or 4 years, there's been a doubling of it. And over the next 10 years, it's expected that the number of valves implanted will quadruple to 280,000. So this is a substantial increase, fairly exponential growth in what will happen with transcatheter implantation. And another way to look at it, of course, is who's doing the most in terms of percent per population, or numbers per million of population. And this just highlights really that Germany is leading the way. They always do, because they usually get reimbursement very early, so they've been quick to ramp up transcatheter valve implantation procedures there. The US took a little while for the FDA to approve it, but they now have approval for several devices, and so their numbers will increase. Our numbers here, we really only have TGA approval for a commercially available device really in the last 3 or 4 months. We still don't have any funding for it, so our numbers are still fairly low in terms of numbers per population. We're about 23 roughly per million population in Australia, which is somewhat similar to other reimbursement-challenged countries in Europe, such as the UK and Ireland and so on. For the surgeons in the group, you may have seen this, but it hasn't yet had a big impact on what's happening to surgical volumes. You can see in Germany, where reimbursement isn't an issue, that the number of, the proportion of TAVIs, the proportion of aortic stenosis treated by TAVI is now reaching above 30%. There has been a small decline over the last few years in surgical volume, and I suspect that will start to increase a little bit, that decline, as more surgeons become interested in doing transcatheter procedures. So if we look first of all at the Edwards program, there's been over that 10 years a number of generations of this, and we now have access to this device on the right-hand side, the SAPIEN 3 device, which is so much better than the original device. It's much lower, it's much sleeker, it's much easier to place, it's much more reliable in terms of where you place it. It has a skirt to minimize the risk of aortic valve regurgitation and so on. We have a series of I have a few slides I'll show you about that. But these 3 devices have been examined in a very large number of patients under FDA trials, and I will touch on those because we have some compelling data from those trials now. But the fact that we've been able to get through 3 generations of this device really in 7 years, I think is pretty extraordinary. But this, you will have seen, the partner trials. The partner trials were twofold. There were 2 trials done. One was for an inoperable cohort. Those patients were randomized to either a TAVI procedure or to medical therapy, usual medical standard of care therapy. And we now have 5-year data for this trial, and also for the high-risk cohort that were randomized to surgery or to TAVI. And you can see that really from very early on, this is for the inoperable cohort, the patients treated with standard medical care, something we've known for a long time, do very poorly. And in fact, by 5 years, there was only 1 patient who was still being treated with medical therapy who was still alive. The patients treated with a TAVI did better, but they're old and they're frail and they're sick, and at 5 years there's still a significant loss of patients there, mortality of some 70%, but significantly better. And if you look at what that actually means in terms of survival, the median survival for a standard care patient was only 11 months. Most didn't make it to 12 months. With a transcatheter valve approach, 2.5 years was the median, and this was about an extra 18 months of usually fairly good quality life, significant improvements in their quality of life as well as their length of life. So for the inoperable group, this is clearly a good therapy. One could argue whether we're really achieving a lot in terms of this elderly, very elderly population, but I think 18 months' worth of quality life is pretty significant. The question's been raised about the durability of these devices, and you can see here these are 5-year data. There really isn't anything much to suggest that out at 5 years there is any decline in the hemodynamics of the TAVI population's valve. They look just as good at 5 years as they did at 1 year. Now, in the high-risk cohort, this is patients randomized to either surgery or to TAVI, there was really no difference. You can see here that the curves are parallel after the first slight increase in surgical risk in the first few days, but basically the curves for a high-risk group are superimposable. So you get just as good an outcome with a TAVI as you do with a surgical repair if you're elderly and frail and have a high risk. There was a small but non-significant difference in terms of median survival, but both groups did pretty well, getting out to close to 4 years in these groups. We now have the SAPIEN 3, and as I mentioned earlier, this is a better device all round. We would expect the outcomes to be better still, and we have started now to see some data from SAPIEN 3. There are 2 ongoing registries. These are not randomized trials, but there are 2 registries that are going to be compared with some of the original partner outcomes. So there's a high-risk group of 580 patients, and then a low-risk group with an STS score of about 4 to 8, about 1,000 patients who've been included in these trials. So 2 different arms. Again, the high-risk ones you've seen some data on, but now this is starting to move into that intermediate risk group, the STS score of 4 to 8, which would normally be considered surgically operable. So what do we see? Well, in the high-risk group, these will be 30-day outcomes. In the high-risk group, their estimated or average STS score is 8.6. Their age was 82.6, and the majority were transfemoral cases, 84% or so with those. So pretty similar to what we've seen in the original partner group. In the intermediate group, the lesser risk group, the median STS score was 5.2. That was slightly younger, although still not young. And again, most of them were done with transfemoral approach. You can see here the difference between the 2 populations. Fewer of the intermediate group were actually very symptomatic. There were higher incidences of atrial fibrillation and permanent pacemaker, and frailty scores, of course, were higher in the high-risk groups. Just to give you an idea that this group here, the intermediate group, 2/3 of them, 25% of them roughly were not in class 3 or 4, so they were not particularly symptomatic. So they were clearly a lower risk group than the others. This is the high-risk group. I can't see it on my slide, but the high-risk group where at 30 days the mortality rate was 2.2%, the high-risk group. 2.2%, which is considerably better than the previous one. And if you look at the observed versus the expected mortality rate, the observed mortality rate was 1/4 of what the STS score predicted it should be. The stroke risk was 1.5% at 30 days. These are pretty good results for a high-risk cohort of patients. In the intermediate group, the results were even better, 1.1%. You'd hope they would be for a lower risk group. At 30 days, a mortality, total mortality of 1.1% and a stroke rate of 2.6%. Again, the observed versus the expected of only 20% for this cohort of 1,000 patients. This is what I showed you was the US trial. There is a similar registry going on in Europe for CE mark approval, and they are also including a low or lower risk cohort. And in those patients, look at these numbers: 1% mortality at 30 days, major vascular complication rate of 2%, stroke of 2%, and a moderate to severe paravalvular risk of 2%. So low single digits all the way around for an intermediate group risk patients. So I don't think there's any argument with these better, sleeker, more predictable devices. We are seeing a gradual reduction in mortality. We're now starting to look at 1 or 2% for the populations being treated. The stroke risk is now 1.5 to 2% for the low-risk populations. Clearly much better than when we were using bulkier, more difficult to use systems in sicker and frailer patients. Core valve was a little slower off the mark, so we don't have as long-term outcomes for them, but I'll show you some 2-year data from the core valve US pivotal trial. In the pivotal trial, there were 2 arms. Again, it was considered not ethical to randomize the extreme risk patients against medical therapy, so they all were treated. But the high-risk population was randomized to either a core valve or to a surgical valve. And you will perhaps have seen these data. They were presented, the 2-year data were presented at ACC this year. All-cause mortality for the patients treated with the transcatheter, the core valve, was actually numerically and statistically significantly lower than for the surgical group. Mortality and major stroke together, combined as an endpoint, again significantly lower with a p-value of 0.01. And for all other MACE outcomes, it looked pretty good again for the transcatheter approach in this high-risk population. We've had some discussion this morning about the hemodynamics of these valves. Are they any good? And we've known that the surgical valves, as David Muller said this morning, can in some patients leave a significant gradient and a smaller area. This slide just compares the valve area for the TAVI patients compared to the surgical patients. You can see it was higher, and these work better hemodynamically than the surgical valves, with no reduction in function of the valves across that 5-year or 2-year period. The big difference, of course, is still paravalvular leak. There's no question that for transcatheter approaches, we cannot get a perfect result yet, but with changes, the skirts and better placement and so on, the paravalvular leak is becoming much less of an issue. In this trial, the core valve trial, as distinct from the partner trial, mild paravalvular leak was not associated with any adverse outcome. The mortality rates were the same as if you had no leak. It was only the group that had moderate to severe or severe leak where there was still a significant difference in terms of outcomes and survival. Bad leak is bad. A little bit of a leak doesn't seem to be such an issue, particularly for the self-expanding devices that perhaps continue to expand with time over the year or so after they're implanted. This trial, the core valve pivotal trial, looked at a number of subgroups, and they did single out the group that had the lower STS score, trying to decide if it's time to start moving into lower risk patients. And you can see that by this analysis, they actually look better than the higher risk patients. If you look at it with a Kaplan-Meier curve, in fact, that seems to be true, that the lower risk group did pretty well compared to the surgical group as well. So this is not a reason to start moving into the lower risk groups. We need better quality data than that. Those data are starting to come through. We've seen that if you look at the risk, overall risk for outcomes of the intervention, the partner trial and the US core valve pivotal trial, we're working with these patients, the inoperable patients and the high-risk group. So the partner trial I've shown you are now moving into the intermediate group, the 4 to 8 STS score, but those are not randomized. The core valve is doing a randomized trial with the TAVI trial, but that won't be available for a little while. They've been pipped by a group in Scandinavia who did the NOTION trial, and I'll show you that briefly. The NOTION trial was a randomized trial, not all that many patients, 280 patients, treated with core valve or surgery, and these data were presented in the last couple of months. The STS score is very low, 2.93. This is a low-risk group of patients. The Euro score for these groups was only 8. So this is certainly the patients you would consider now would be surgically eligible. The all-cause mortality in this trial was very similar between the two groups. A little higher than you'd expect. I've shown you some data for low-risk patients. You'd expect even for the TAVIs to be lower than this, but certainly the surgeons, I would think, would be unhappy with that number of 3.7% for a low-risk group at 30 days. But nonetheless, In this trial, there was no difference in terms of survival. Small trial, you wouldn't necessarily expect it to be all that different. But if you look at secondary outcomes, this is what you would expect, and that is that there is a difference in bleeding, there is a difference in renal dysfunction after the procedure, much higher incidence of atrial fibrillation after surgery. We've heard that discussed this morning about the risk of that causing strokes and so on in the months after surgery, and it's high. It's high. In this trial, it was 60%. And in this trial, pacemakers were still a big issue of 34% in the core valve group. So this is the sort of things, the trade-off, I guess, of some of the greater risks of bleeding and atrial fibrillation against pacemakers that you might see as you go down into a lower risk group. You have to weigh up the pluses and minuses of that. But even in this low risk group, very low risk group, there didn't seem to be a huge disadvantage in doing a transcatheter approach. So you'd hope and expect that as we move into the lower risk patients with better devices, that we should be able to start to streamline the procedure and move along, and certainly that is starting to happen. You start to see that Belfast, for example, is showing that their median time to discharge now is only 2 days after a transcatheter valve procedure. At St Paul's Hospital, which is where most of the work for the Edwards program has been initiated anyway, they've started a trial looking at next day discharge for some patients. They did a pilot trial of and estimated and identified 85 patients of 385 potential candidates, or just over 20%, who might be suitable for early discharge. So these were more robust patients, had good supports at home and so on. And in that group, 70% went home the next day as planned. This is a newsletter from the multi-center trial now that has been initiated, and you can see already that of 23 patients, the first 23 patients enrolled in this next day discharge protocol, 90% went home the next day. So this is becoming really a much less involved and much less, you would hope that that would be associated anyway with a much more cost-effective model for getting people into and out of hospital quickly as you move down into the less frail patients. So I think what I would conclude from these data is the following, that the third generation devices are clearly much lower profile. We're down around about 14 French for most of them, so that means we can treat down to about 5 millimeters transfemorally. The delivery does seem to be much more predictable, and we're much better at knowing where we want to put them. And this has translated, and will continue, I think, to show improvements in mortality, stroke, and major event rates. We would expect to see that there will be a shorter time to discharge, much better cost effectiveness. We've seen in the trials that there is an improvement in survival for inoperable patients. There are similar outcomes to surgery pretty much for all patients in terms of mortality, and there are some emerging data suggesting that we should be starting to look a little more seriously at moving down into the lower risk patients. There are issues, though. We're certainly not there yet. This is an older slide I've used, and I think we can say we have improved access injury, we have improved the vascular complications, paravalvular leak is better. We now have devices that can be retrieved, which is allowing us to place more accurately, and that will reduce the need for pacing. There are still some questions, certainly in the surgeon's mind, about durability of the devices. I think we have 5-year data that's looking pretty good, but no one will be happy until we have 10 to 15-year data before we start to consider treating younger patients. And there are, of course, other subgroups. I'll just touch in the last few minutes on a couple of those issues. I do think that we cannot afford at all to become complacent about this. The outcomes look good, but they will only be good for as long as we are very careful with what we do in terms of preoperative evaluation, making sure we know what's going on with the access, making sure we're careful in whom we select for these. This doesn't run, I'm afraid, but I still like crossing over. I still like being able to identify exactly where to puncture, so I know I'm going through the anterior wall. I'm above the bifurcation. I'm not going to injure anything. I like to come out with a catheter across that shows me that I don't have a dissection, that I don't have any other perforation or injury. It means that you can move fairly quickly if there is a problem. We just should not see this sort of thing ever again. This is the sort of thing that makes your heart stop and feel miserable, that some poor, like this wasn't mine fortunately, but that sort of thing really should not be happening now with these lower systems. If it does, we should be able to deal with it. We should know how to put in a covered stent quickly and to deal with any of those sort of complications. We know that we have to put devices higher than we have been used to and higher than we're perhaps still comfortable doing sometimes, because it does reduce the need for pacing. It does reduce the paravalvular leak. This is true not only for core valve, but I think also for the SAPIEN 3 valve. It has been shown that there will be a lower need to post-dilate, a lower leak rate, and a lower need for pacing if you use the appropriate or optimal position for deploying this. This isn't working either, but it just shows what happens when you start trying to deploy high all the time. Every now and then it will pop out. If it does, the core valve of days gone by has meant you've had to drag it across the arch, take it out, wash it off, get a new one and put a new one in. And you can just imagine what that does to around the arch. It's like a cheese grater, and you just take off all that atheromatous disease. Most of the strokes we've had have been related to this sort of problem. Fortunately, now we have repositionable devices, and that really shouldn't be an issue anymore. You don't have to drag it back out. You can recapture it, redeploy it in the annulus, and this is the Lotus valve, just showing again that you can, if you do get heart block at the time, or you have inadequate, or you have too much aortic leak, or the valve's too high or too low, it's fairly easy to recapture and redeploy, and you should be able to reduce some of those issues with these newer devices. Similarly, one of the feared complications is obstructing the coronary artery. This is particularly true doing valve-in-valve procedures when the prosthetic valve leaflets may be a little higher than the native leaflets, so that at least with a removable valve, you can put it in. If there is a problem, we can recapture it and take it out. Strokes, again, we've seen fewer of these, fortunately, and so I think some of the issues we've talked about will show that the incidence of stroke will be much lower. When you look at the anatomy, it's surprising we don't have a lot more strokes. There are ongoing trials looking at a number of devices to deflect some of that embolic material, but time will tell whether that's really necessary. So I think I will leave it there, Mr. Chairman. We have made great strides, great progress over the last 10 years. I think it will continue to be an exciting area to watch. I do think we will gradually move into lower and lower populations, risk populations, and I hope the surgeons embrace it with the enthusiasm that the rest of us have. Thank you.